I'm Peter Block in Chicago at the American Heart Association annual meeting, and I'm here for On the Scene. Dual antiplatelet therapy continues to be a complex issue, and with me is Stephanie Schipke from the Deutsches Herzzentrum in Germany. And Stephanie has just gone over a dual antiplatelet yet again, another trial. So Stephanie, tell me about what your trial is, what's different about this trial and what you found.
So Isar-Safe was designed to compare two different durations of clopidogrel therapy, 6 versus 12 months. So it tested the hypothesis that 6 months of therapy is non-inferior to 12 months. It was a double-blind trial, so the first double-blind trial to assess these different durations. And what is also notable about the design is that we randomized patients at 6 months after PCI. So patients that were on clopidogrel at 6 months were randomized to either an additional 6 months period of clopidogrel or to a 6-month period of placebo therapy.
Okay, so having said that, sort of an interesting design, isn't it? But having said that, let's cut right to the chase. So what did you find? What are the differences between these two groups?
So the main results of the Isar-Safe trial is that there was no difference in net clinical outcome in patients assigned to 6 or 12 months of clopidogrel. However, it must be noted that the events rates were incredibly low, much lower than expected, and the trial was stopped prematurely after inclusion of 4,000 patients.
So the event rates, as I remember, are somewhere less than 2%.
Yes.
I mean, crazily low event rates. And that, of course, makes it very difficult to find any difference in any population unless you have 50,000 patients.
Yes.
So is there a difference at all? Or tell me about the demographics. You had a lot of patients that had acute coronary syndromes.
Yeah, that's right. So we included patients that had an acute coronary syndrome. 40% of the patients had an acute coronary syndrome at the time of PCI. So according to guidelines, these patients would have to be treated longer. But actually at the subgroup analysis, we did not find an interaction of subgroup with treatment effect. That was interesting. So, of course, you have to be careful. You can't draw any definitive conclusions about patients with acute coronary syndrome based on these data because the event rates were so low.
Understood. So let me ask you the difficult question. If you were to have a stent tomorrow, hopefully you do not need one, and I'm sure you don't, but if you were to have a stent, what does this trial tell you about what you would do for yourself?
I think first it's important to know what kind of stents you have implanted. Isar-Safe was a trial with predominant use of new generation drug-eluting stents. So I think the situation would be difficult if you had implanted a paclitaxel-eluting first-generation stent. But I think with newer generation drug-eluting stents, we have now reassurance that we can shorten that duration from 12 to 6 months.
What about bleeding complications? I forgot to ask about that. Did you see any increase?
Yeah, so there was no increase in TIMI major bleeding, but we did some additional analysis, and indeed there was a numerical but non-significant increase in TIMI minor bleeding. But when we looked at more recent and more sensitive measures of bleeding, like those of BARC, there we found a statistical significant increase in bleeding with a prolonged therapy.
Okay, so another complicated trial. Dual antiplatelet therapy continues to be a big and important issue, of course, for all of us. But for me, I think I'm learning that depending on the stent you have, the last generation stents seem to be doing well and perhaps don't need it as long. And perhaps also patient characteristics still play an important part.
Yes, definitely. I don't think we will ever have one definite answer about the question of the optimal duration of dual antiplatelet therapy. There won't be a one-size-fits-all approach. So I think the future will be individualization of therapy, so balancing the ischemic and bleeding risks of the patients. You have to look back to the history, what are the risks, and adapt therapy accordingly.
There's a teaching point. Thank you, Stephanie.
Thank you.